Ladies and gentlemen, welcome to this edition of the Cameroon Townhall for Healthcare Professionals, and Happy New Year to everybody. This is our first session for the year 2023. We are so excited to see all those who are tuning in for this first edition. We want to thank all of you for having been here all through 2022. We had an amazing year, as you heard from our chair at the closing session. And we are also hoping that this year will be exceptional with so many promising activities and speakers. So I want to thank all of you for being fervent participants of the Cameroon Town Hall for Healthcare Professionals. And as usual, my name is Elvis Ndasi. I'm moderating from New York. Today, I shall be moderating the session with Dr. Brian Tegomo from Nebraska, USA. And of course, we have our chair, Dr. Muno, who is here with us. And subsequently, we might have some other co-moderators who will dial in as their schedule permits. So once again, you're welcome. And before we start, let me pass over to Dr. Brian. Brian, Happy New Year.
Yeah, Happy New Year, Elvis. And it's really good to see you in the new year, 2023. And Happy New Year to everyone. And I really, truly, really excited about today and the conversation we are going to have today. I think it's an important subject, this topic around pandemic preparedness and how do we respond to public health emergencies with international concern. As you all know, it's really been on the media. So I'm really excited about this. And I thought one of the really unique things about our speaker for today is really the fact that he was one of the first people to respond to the really early on in the COVID-19, one of the first introductory cases of COVID-19 in South Africa. And it's really unique, and he really brings a lot of experience responding to Ebola and other pathogens. So I'm really thrilled, particularly now that we are having these global conversations around the importance of pandemic preparedness. How do we build local capacity? How do we build, surveillance mechanisms locally and, nationally and globally? It's so important. And I'm really excited, Elvis. I've been looking forward to this presentation for a really, really long time. Thanks.
Thank you, Brian. Obviously, you should be excited because I know you have done a lot of work when it comes to, surveillance and in Africa with CDC. And so this is your area of, passion and interest and your area of work as well. So I'm sure you're going to have a very good time with our guest speaker today. Hello, Dr. Mono, our chair. Happy New Year.
Oh, thank you, Elvis. Happy New Year. And still just want to thank everyone who is here today and just to thank God that we have all made it to the new year. And my special thanks to all the moderators and those who are here today and those who cannot make it due to their busy schedule. You guys have been wonderful, your time, your dedication to this process, and a special thanks to all our speakers. And also to let everyone know that this platform is an open platform where if you know anyone who has a message that they can change Africa, change Cameroon, and change the world, this is the right platform for them. We're going to provide the space and for us to have a town hall, which is a format which we love because we're not here to lecture each other. We're here to have a discussion, to be amicable, to be friendly, and to agree and disagree amicably. So Elvis, thank you very much, and over to you.
Thank you very much, Dr. Muno, for your chair and for your leadership over the past 3 years, always working so hard to make sure that we get the best of speakers in the town hall. And if you are joining this session for the first time, this is the Cameroon Town Hall for Healthcare Professionals, a platform that brings together healthcare professionals of Cameroon origin from every part of the world. And right now, I keep always updating you with the statistics. We are still at 35 countries, and our membership has grown now to 1,720 people. These are people who have dialed in at least once in our session, and we keep growing in numbers, but also in impact and the different people that are finding this platform very useful. The numbers that attend the session currently is at 24. It will keep increasing, but what is more exciting is the number of people who go to our YouTube channel to view these recorded sessions of Cameroon Town Hall. The many students that are appreciating the knowledge of medical students, nursing students, lab technicians, everyone in healthcare. So we want to thank all of you for being the part of this town hall. As you heard from Brian, what happens when a country detects a pathogen for the first time? Now you're going to meet someone who was right there at the epicenter when the COVID-19 virus was first detected in Africa. You're going to meet this dynamic person before he's introduced by Brian, who is going to tell you who he is. Please just take a moment and watch what happened.
An outbreak spread in the beginning of 2020. Every nation was bracing for its arrival on their
Sorry,
soil.
I will have to stop and reshare so you get the sound of this presentation, just to be sure that the quality is okay.
But what happens when a case is detected in a country for the first time? Well, you're about to meet the scientist who was the first person on the scene when COVID arrived in South Africa.
It was a normal day at the office, I came to work, started checking my emails, had tea, had a few meetings. Then it was around, I think, 10 o'clock or so, when my phone rang. I got a call from Dr. Natalie Mayet, who is the Deputy Director of the NICD. She doesn't call me very often, but I wasn't expecting that it was the news she was about to announce. And she told me, Villian, we got our first case, pack your bag, you have to go to KwaZulu-Natal province.
Dr. Villian Motaze is the exact person you'd want on the job of containing a deadly outbreak. He's a medical doctor who practiced for 4 years in his home country of Cameroon before earning his master's degree in epidemiology in South Africa, where he's currently completing his PhD. He's responded to 2 Ebola outbreaks in the Democratic Republic of Congo in 2018 and 2019, and now he's the head of the Notifiable Medical Conditions Program at the National Institute for Communicable Diseases in South Africa.
So the first COVID case in South Africa was a gentleman who returned to South Africa from a holiday trip in Europe. A few days after they returned, he was feeling unwell. So he went to see his doctor, and given the signs and symptoms that he presented, the doctor thought that this could be COVID. And when the sample was tested at NICD, it was confirmed as being positive for COVID.
Villian knew that containing this case would require top epidemiological talent and assembled an incredible team to get to work.
First, there was the field team deployed from the NICD, which consisted of myself and my colleagues. We were tasked with tracing and collecting samples from contacts of the first case and instructing them on isolation protocols. We collaborated with the local response team that had been established by the KwaZulu-Natal Provincial Department of Health. We also coordinated with the team based at the NICD campus in Johannesburg, where the national response team was organized and sample testing was being conducted. Finally, there was a national incident management team, which included representatives from various government departments and international partners like the World Health Organization.
There was a lot of stakeholders that came together in order to work to make sure that all these activities were a success. The overall objective of my deployment on the ground was simply to stop the spread of this infection from this one individual who had been diagnosed from spreading to other people in the community. Since the first case that was diagnosed was already identified and this person was already isolated in the hospital, for me and the team, we had to actually go to each and every one of the contacts of that first case. It was contacts who traveled with this gentleman. It was individuals seated on the plane with him, and it also involved his family members who had met him when he returned from this trip.
I asked Villian to take us through one of these contact visits to collect samples.
Collecting samples from an infected individual is actually a risky procedure, and if not done properly, the person collecting the sample or the individuals around might get infected. We had to make sure that we had the appropriate personal protective equipment or PPE in order to gain the person's trust. We had spoken to these people prior to going to the houses, and when we arrived, we called on the phone to say, okay, we are outside, this is the car we're driving. And in order not to attract a lot of attention from neighbors, who might now start stigmatizing this individual, we entered the property in reverse, and then we went out with our normal clothes, we opened the booth, and then we changed into our PPE outside, outside the house behind the car. That enabled us to now walk into the person's house without being seen by the entire block. We didn't want to raise any alarm. So when we got into the houses, we had to guide the patient or the individual to sit in a specific position. Then we collected the samples, and then we had to sanitize every place we had touched, every surface we had touched before we left. We had to explain to every single family we visited how they had to carry out isolation procedures. So we had to explain to them how to separate themselves from their family members, how to use their own utensils, how to sleep in their own bedroom, use their own bathroom, basically separate from their family. And that is never an easy thing for someone to do. And when leaving, it was the same procedure we had to follow. We had to, remove all our personal protective equipment at the boot of the car and put it in a biohazard bag and close it, and sanitize it and put it in a specific corner of the boot before we drove off. So it was really a tricky procedure. It was a bit difficult, because somebody's entering your house wearing all this gear and you can't really see the person's face. Bearing in mind that some of the time we had to do this at, 11 p.m., even midnight. Some people were kind enough and collaborative enough to open their doors to us at that late hour of the night.
If you think that's intense, Villian and his team had to come up with equally stringent protocols for packing, cooling, and shipping all of the samples they collected back to the NICD for testing. The contacts lived in the cities of Pietermaritzburg and Durban, which are an hour apart, so the team had to travel back and forth as each contact returned their calls. And the most amazing part?
In order to visit all the other contacts and collect all the samples and batch and send, it was about 25 individuals we had to meet and collect samples from, and we did all of that in about 3 days.
As I was listening to Villian describe these experiences, there was, of course, one big question on my mind. What was the outcome?
I can say we contained the first case. There were a couple of positive individuals among the contacts of the first case, and there were a number of symptomatic contacts who eventually tested positive for COVID. And they were isolated, following the national guidelines in South Africa, and they were treated. There was not widespread transmission of COVID from this group of people. That suggests to us that they complied with the advice we gave them with respect to self-isolation at home and the measures they had to take to distance themselves from their relatives and friends and family. We did not have any positive COVID case among the field team that was on the ground. So I think that was a success on our part. We succeeded to respect the infection prevention and control guidelines when we were wearing our PPE and when we were interacting with the patients or the individuals.
South Africa did ultimately experience a severe COVID outbreak, and Villian explains how this can happen even after such a successful first case containment.
Well, eventually, a number of other cases were detected in different parts of the country, and many of these cases were not linked in any way to this initial cluster of cases that I went to work on in the field. That strongly suggests that there were multiple importations into the country by different individuals. It might have happened that many of cases were asymptomatic or had only mild symptoms. They were not identified and isolated rapidly enough to stop spread. I think that these best practices from this experience could also help in responding to future outbreaks or to future importation of cases. If these lessons are shared and there's a lot more training of personnel that is going to be deployed in case there's an outbreak which is detected, that will really be helpful, in controlling future outbreaks in South Africa. One of the biggest threats, I would say, to successfully containing an outbreak is the way information flows, to and from the public. There's a lot of misinformation out there. Sometimes it is deliberate and sometimes it is not. But the COVID pandemic has definitely showed us that, social media especially is very powerful. The population has to trust what you're doing. If the people I was going to see didn't trust me and I didn't communicate openly with them, they wouldn't have opened their doors to me at midnight, So that is just a few individuals I dealt with, but from a population point of view, the way healthcare workers interact with the communities has to really be improved such that people understand what we're doing, people trust what we're doing, and that leaves less room for misinformation. It has to happen also when there is no outbreak, because there's the preparedness aspect. You don't only respond to outbreaks, you need to prepare because these things happen. This is not the first pandemic, and this definitely will not be the last pandemic.
Billion, thank you so much for sharing your story with us and for all of your work at the front lines of this pandemic. We really appreciate it and the work that you're doing. And thank you to the Vlog Brothers and Team Halo for supporting this work.
Yeah. Thanks a lot, Elvis, for sharing that video. It had so much information packed there, and I when I saw this earlier, I was really blown away and really humbled that Dr. Motaze is just the ideal person that we need to have, and I think his insights, his experience in pandemic, this kind of response is really critical. So I'm really deeply honored to present Dr. Motaze here at the town hall, who is going to talk to us about responses to public health emergencies of international concern, and he will highlight some of his experiences responding to COVID-19 and other infectious disease. So Dr. Motaze he's a physician, and he has a PhD in epidemiology. He did his medical training in Cameroon at the Faculty of Medicine and Biomedical Sciences of the University of Yaoundé 1, excuse. So he's been a medical epidemiologist based at the Northwest University in South Africa, where he spends a lot of time to supervise graduate students who are doing their master's or doctoral projects in various aspects of epidemiology, be it pharmacoepidemiology, infectious disease epidemiology, or health system strengthening and non-communicable diseases. So his breadth of expertise really crosses across a range of subjects, which has really been quite fascinating. So when he finished his MD in Cameroon, he spent about 4 years with practical clinical experience in Cameroon. So he knows the realities of working in a low resource setting in Africa. He understands the burden of of infectious diseases and what it looks like being in a rural setting, which is a very unique experience for all of us, particularly when we leave from Africa and we come to the United States and get extra additional education. We have this additional lens on global health equity, which I think is really useful when you've had the experience of practicing medicine in a very low resource setting. Dr. Motaze also did his master's in clinical epidemiology at Stellenbosch University, where he joined the Center for Vaccines and Immunology at the National Institute of Communicable Diseases in 2014. He did his PhD at the same university as Stellenbosch, and he focused a lot on rubella and congenital rubella in South Africa. He spends a lot of time conducting systematic reviews and healthcare interventions, and facilitates a lot of training in systematic reviews and evidence-based practice at the Stellenbosch University in South Africa. So he's been deployed multiple times by the World Health Organization to support outbreak preparedness and response following the Ebola outbreaks in the DRC. He's a consultant for the World Health Organization as well. So Dr. Motaze really has a broad range of experiences and expertise, and I'm really thrilled that we have him with us today, and it's really a deep honor, Dr. Motaze, to have you, and I'm really looking forward to your presentation, looking forward to the question and answer session. So if you have questions, you can drop them either in the chat, or at the end of Dr. Motaze's presentation, you can also raise your hand, and let's have a discussion about this very important subject on how do we prevent this from happening ever again, and how do we build local surveillance capacity in our own countries in Africa, and how do we prevent these kinds of things.
Thank you very much, Brian. Good evening to the fellow colleagues. Good evening to Dr. Mona. Good evening, Elvis. It's a pleasure to see your faces in this new year. And it's an honor for me to be the first presenter at this Cameroon Townhall for Health Professionals in 2023. Thank you for the invitation. I'm going to go ahead and share my screen. So please just let me know if you can see my screen in presentation mode.
Yes.
Yeah.
Okay, so the title of my presentation has already been given, so it's responding to public health emergencies of international concern in Africa, experiences from the field, or challenges and the way forward, as the title of the advert shows. So I'm going to follow this outline briefly, and don't hold it against me if I don't strictly follow the background, because this is some sort of interaction and some sort of discussion. It's not really a lecture. So I'll start with this specific presentation, this slide. Many people wouldn't actually imagine this, right? That this is actually what is happening. I couldn't find any more recent data, but this is the easiest one I could come across from the Wellcome Trust. There's been over 1,300 epidemics that have happened from 2011 to 2017. So if you add the number of years from 2017 to 2023, there have been a lot more. And I don't know, rather unfortunately or fortunately, I don't know, pandemics tend to overshadow everything else that is happening. Because if you put the disease mortality and morbidity that's happening due to all these other thousands of epidemics that happen at low level, they possibly can add up to the same magnitude of impact on individual health as the pandemic. So the issue with the pandemic is simply that many people have a lot of effects on their lives due to the measures taken to control the pandemic, not necessarily due to the pandemic itself. So, of course, number one, you can see is cholera, which surpasses all the others. And if you follow the news, you would actually see what's happening today in terms of things like cholera. But there's a lot of other things out there. And many of these diseases actually have a much higher mortality than COVID. My slides seem to have frozen. Okay, there they go. Okay, so I'll just briefly go through some definitions just so that we're on the same page. I know there's different people who are specialists in different fields, but there are many people who are familiar with all these terms. I'll just quickly go through them just so that when we're speaking, we are on the same page, right? So an epidemic is an outbreak of a disease of a particular disease in a specific population within a specific geographic area, right? That's an epidemic. Now, when you say an endemic, it means that before it gets to an epidemic, usually many diseases are endemic, right? So an endemic disease is the amount of any disease that is there on, like, baseline means every day on a day-to-day basis. Now, when a certain disease is present on a day-to-day basis at a certain high level, then it's called hyperendemic, right? And I've previously given the definition of an epidemic, which is an increase in cases in a specific area. But now, when we talk about an area which is very large, that spans across many countries or continents, now we talk of a pandemic. Nobody's new to that term. In fact, even people who study literature know what a pandemic is now due to the COVID-19. But yeah, these things happen. So an infection is the entry, development of an infectious agent in a human or animal. Now, this pathogen enters and multiplies, right, or develops. Now, whether the host or the infected organism develops symptoms, that is, develops a disease, is irrelevant, right? That has got nothing to do with the term infection. So once there is an entry and multiplication, development, establishment of a pathogen, it is an infection. Now, a reservoir is a habitat in which the infection agent normally lives, right? So the ground, for example, is a reservoir. I don't know, you can have things like the anthrax, plagues, or rabies that have animal reservoirs, right? And there's other environmental reservoirs. So it is there all the time, you can find it there. And this becomes particularly important in diseases like maybe measles that are targeted for elimination because there's certain criteria that the disease has to meet in order to be eligible for elimination. You can't eliminate a disease that you have everywhere in the environment, right? Or you can eliminate it in human beings, but you cannot eradicate it, right? So, yeah. Zoonosis is an infectious disease that is transmissible under natural conditions from a vertebrate animal to a human. So it's important to say under natural conditions. So you don't need to tweak the pathogen in any way. It's part of its life cycle, if you can put it that way, to live from an animal to a human. Now, the links at the bottom, you can follow them to find where the definitions are taken. They might slightly differ from other definitions that you might have come across, but this is not a talk about definitions, right? We're just trying to be on the same page. Now, we're talking about emerging infectious diseases, which are diseases that have recently appeared within a population or whose incidence or geographic range is rapidly increasing or threatens to increase. COVID-19 is one of them. There's others. There's Ebola, and there's been the two other coronaviruses, which is SARS and MERS. Now, a re-emerging infectious disease, a disease whose incidence had significantly declined in the past. So they were dropping, and we thought we are done. We are okay with this, right? Like measles, for example. Those of you living in the US, you probably must have heard about this. But now these diseases whose incidence has declined have started increasing in recent times, and that is largely due to human behavior. In fact, I can say it's our fault as human beings. So, yeah. Now, what is very unfamiliar to many people probably is what you call the international health regulations. These are the regulations that provide the framework that make it obligatory or compulsory for a country to inform other countries or the WHO, for example, when you have a new health event. So without these regulations, a country could have, like, if China had the first COVID-19 cluster, they were not obliged to report to the WHO. The fact that they reported is because of the international health regulations. And if you have some spare time and you are not in public health, you can go through it. It's a very important document, and you'll quickly understand why. Now, a public health emergency of international concern is an extraordinary event which constitutes a public health risk to other states or countries, right, through international spread, and potentially requires a coordinated international response. So this is one part of the evolution of a pandemic, because you all heard there was a certain time where COVID-19 was declared a public health emergency of international concern before it was declared a pandemic. So there are other conditions that are declared public health emergencies of international concerns, like maybe Ebola, but never get to the stage of a pandemic because efforts that are done curb the spread. So now that we finished talking about it, this is a link that I'm sharing. It's publicly available. You can Google it and pass through the WHO website, and you can get to it and read it for yourself. I'm not going to dwell on that. Now, when we talk about the impact of outbreaks, outbreaks usually are associated with significant morbidity or mortality. Usually these impacts are higher in low resource settings. And the irony of these statements is that, low resource settings like sub-Saharan Africa had actually some of the least impact due to the COVID-19 pandemic, right? How strange that was. There's the number of papers that have been published and editorials and all kinds of discussions that queried why was it so, why did Africa not suffer? Many people actually thought at the start of the pandemic, myself included, that there'll be bodies lying in the street in Africa. Somehow Africa, sub-Saharan African countries didn't really, it didn't happen as many people thought it would. Let me put it that way politely. Now, many outbreaks, like I said in the past, do not get global attention, right? Because there's just so many of them. I mean, 1,300 of them in 7 years, from 2011 to 2017. You can imagine that it's not possible for global attention to be called upon for 1,300, so it's not possible. And if you get attention, and if you follow the news, and you would actually notice that many of those that get the highest attention are those that get attention in the high income countries, right? It's a blunt truth. It has to be said. Monkeypox has been in Africa, for example, for many years. It was never at the center of global attention until it spread, so these things happen. And as Africans, as role players in Africa, we need to start asking ourselves, how do we make not necessarily things to have international attention, but how comes African problems can get attention on the African stage and be dealt with on the African stage. The most important reasons maybe, I don't know, I can't say why these things get more attention in such circumstances when it's in the Western world or the high income countries, is because that's where the resources come from. But you now see the tight link between resources and actually public health and how this impacts what gets attention and what gets funded and others that do not get any attention or very little attention. So when you want to control an outbreak, the measures you institute can actually interfere with the day-to-day lives of people, and the COVID-19 pandemic showed that. It happens all over the world, and actually, China just got out of some targeted lockdowns a few weeks ago, and this has real life consequences on people's lives. Whether it's the health systems or it's simple trade, the education of children, sociocultural activities, there is a lot of impacts, and you can see that only in this estimates were done after the pandemic, the outbreak. It wasn't really a pandemic of SARS in 2003. You saw that there was 40 billion, the economic impact, $40 billion. That's not small change, So sorry, I'm skipping ahead of myself. So if you want to see all these emergencies that are happening, you can simply go to the WHO World Health Emergency Dashboard, and all those dots you see are events that have happened or that are currently happening. And if you go on the live website, I'm not going to do a demo now, but you can go on the live website, you click on each of those bubbles and it tells you some information about the emergencies. So there's emergencies happening all over the place, whether it's flooding, whether it is droughts, whether it's some other infection, whether it's plague, cholera, measles, these are all emergencies that the WHO is dealing with all the time. And, they really have their hands full. Now, you can see that here, we're looking at the current number of events is 211. These are events that are currently being monitored or being responded to. But I will leave you the pleasure of going to the WHO World Health Emergency Dashboard and have fun getting some new information on these things. So now, let's talk briefly about some emerging pandemics. And the most popular example that we all know, what I will give, maybe before the COVID-19 pandemic, was Ebola. And as many of you know, Ebola is a zoonotic viral disease. It has a natural reservoir in fruit bats. And that might explain why you get repeated epidemics in these areas of the rainforest where there are huge colonies of bats, millions of bats, in certain areas, and these remote areas that are usually the source of these pandemics, because it gets from the bat into a smaller animal, and then this animal gets infected, and then a hunter gets this animal, takes it home, and that's how it starts spreading in humans, And the good thing with Ebola, I don't know if there's any good thing, but the positive thing is that it's transmitted by direct contact, right? So I didn't want to go into definitions of contacts, but you need to have physical direct contact with the body fluids or another human being who is infected, which probably explains why Ebola will probably never be a pandemic, because it's easy to stop, Now, it might come as a surprise or not to some of you that, since the first Ebola pandemic in 1976, there have been many, many Ebola outbreaks up to last year. In fact, it's only last week, or no, probably this week, that Uganda declared the end of the current epidemic. So there have been many Ebola outbreaks, and there will be many more, But the good thing is that we now have a vaccine. So whenever there's an epidemic, it's more or less easier to stop it. Before the vaccine was developed, Ebola outbreaks were controlled and stopped. But with the vaccine, it simply makes our lives easier. Just to point out here that vaccines alone cannot do anything. Vaccines are just one of many interventions that can stop a pandemic even. They are equally important because they make our lives a lot difficult. They can help stop the pandemic a lot quicker, But while you are advocating for vaccines, in case you come across some anti-vaxxers who can say, before vaccines we were doing this. Yes, it's true. But you don't want to spend 1 year stopping an epidemic that you could stop in 6 weeks using a vaccine, Who accounts for the additional, 46 weeks that people are dying probably. So, yeah. And one thing that actually happened with Ebola, it was actually one of the first times where there was this accelerated vaccine development pipeline. So there was an accelerated timeline for the development of the vaccine is not to say the first time they started working on the vaccine at all was in 2014, for example. No, it simply means that there was an accelerated timeline in terms of pushing these candidate vaccines to clinical trials and getting them actually done. And from 2014, when there was a huge epidemic in West Africa with many imported cases to Europe and America, you can see the trend. Now there were lots of trials, and the trials ended in June 2016. And by the next year or two, the outbreak was declared over, and there was already the vaccine that was pre-qualified, So it's just to point out that COVID, although COVID was a lot faster than this because it was in the space of a couple of months, it's not the first time that the timelines for development of something important is pushed. It is possible to push these timelines, but it doesn't mean that whatever is developed is not efficacious. So for us to remember. So like I showed before, the economic impact of epidemic SARS, the impact was over 40 billion. We are still in COVID. COVID has not yet been declared over, if I can say, but you can only imagine that it will be several, probably 100-fold, this 40 billion, in terms of the global impact. But that's not the only impact, right? There's impact on education, For example, when we're talking about Ebola outbreaks, so 70,300 children lost a parent or both to the Ebola outbreak in West Africa, and there was losses to education because schools were closed, so there's other impacts. So skipping from a very deadly Ebola with a high case fatality rate that can go from 30% or up to about even 80%, we go to COVID, which has a case fatality rate of barely 3%. And it is possible that the mortality of COVID is a lot lower because we know that there's a lot of asymptomatic infection. So many people who get infected never will get diagnosed. So the mortality is probably a lot lower, and it's caused by a coronavirus, just like SARS and MERS. But the reservoir, we're not yet too sure. It's thought to be a bat, right? But there needs to be an intermediate host from the bats to the human, which nobody knows up to today. Or if somebody has that information during the discussion, you can please provide for us. I must admit, I didn't really search today before presenting the slides. Now, SARS has had many variants, right, since of concern. Let me put it that way. There have been other variants of interest, as you might imagine. Now we're dealing with Omicron that has had so many sublineages, but this is what viruses do. Viruses evolve, right from HIV. We know that these viruses, when a person gets infected, the virus starts mutating. It's part of their lifestyle. It's like if you move from a town which is freezing to a town which is very hot, at first it's unbearable almost, but after some time, you can actually wear a pullover in the place which feels hot. So that's what viruses do. They mutate to adapt, and it should be no surprise. So I just wanted to point out some key dates, like the announcement of the first cluster in December 2019, which is why it is called COVID-19, in case some of you are wondering why it's not called COVID-20, because the pandemic actually happened in 2020, but this virus the cluster of cases was identified in 2019. So a few weeks after that, the genetic sequence was published by China, and then the first cases were detected outside China, second week of January. Fast forward to the declaration of a public health emergency of international concern 2 weeks after that, 30th of January. And I'm pointing out South Africa here, not because it's because I live in South Africa and I responded to the case in South Africa and actually do my public health practice as a public health epidemiologist here in South Africa. That's why I cite the 5th of March, which is the famous day I got that phone call. So the pandemic was declared on the 11th of March, and you can all imagine it has been almost 3 years. It's mind-boggling that, it's like 2 years have gone by without us realizing. So these are figures from today, actually on the WHO COVID dashboard this time. And, they've been, 661 million cases. And the deaths have a lag, because mortality usually has a lag for reporting and identification and verification. But there's been over 6 million deaths. So this is not a small feat. I mean, I said before the mortality due to COVID-19 was not that much, was not that high, but 6 million deaths in probably a bit more or a bit less, depending on who you speak to. Some people think that many deaths were allocated as COVID when they were not COVID deaths. They have their points. And the truth is that we don't know, because there's many places where nobody goes and wastes their time to actually, not waste, sorry for that, but nobody has enough time to spend to go and investigate every single death. You know, there's competing interest. So, but about 6 million deaths is not a small feat. So that is what happens. These figures will continue evolving as long as this dashboard is up. So you can look at the website up there and go and check this dashboard. It's publicly available. Now, lockdowns and other restrictions, travel restrictions and all of that put in place due to COVID-19 had devastating impacts on the economy and on education, you know, and there were lots of estimates on this impact, but the focusing on the exact estimate is not the important thing. If you can all remember, wherever you were, there was a point where schools were closed for months. I mean, that is time that can never be caught up, you know, and these are the impacts, you know, which means whenever some of you are making decisions about things like this, you need to think about it, right? And really weigh the pros and the cons, because there's a school of thought that says lots of damage was done due to the lockdowns because people couldn't earn a living. People couldn't feed their families, and it led to other things. They have a say, they have a point, which is true. But unfortunately, it's hard to measure that accurately. But at the same time, measures have to be instituted, because if no measures were carried out, then people will say the authorities are incompetent and that people are allowed to die. So those making decisions are actually on a hot seat. And sometimes the researchers and public health experts and critics that some of you are in the audience should be mindful of that when you engage, you know. So it's not an easy decision to make, and putting yourself in the place of the managers or the decision makers can actually help you to understand how difficult a situation it was. Nothing is perfect and mistakes were made. If anybody says the contrary, then they are probably not aware or they are being intentionally malicious. But there were mistakes that were made, but people did the best they could do. So now what is a re-emerging pandemic? And I will quote cholera in this case. And many of you must have known about cholera or heard about it or treated patients with cholera. It's contaminated, it's transmitted through contaminated food or water, right? And the famous John Snow, whose picture is here, who solved a cholera epidemic in England in 1854, how many years ago, just by doing basic epidemiology. He was not a trained epidemiologist, right? But simple common sense, that's the backbone of epidemiology and most public health things. It starts with simple common sense and you can solve a lot of problems. You don't need a complicated mathematical model, you know. And by just pinpointing where cases were and where they got their water was, you could identify the source of the outbreak and stop it. So yeah, now cholera is back in full force. It can kill within hours, and it requires a multi-sectoral approach. You know, there's a whole global task team or task force on cholera, and you can follow the link at the bottom there and look at what they do, but it needs a lot, you know, and you can see all these key interventions that are put there. Vaccine is also one of them. Again, to emphasize that vaccine is not the only solution, it's one of many solutions. If you don't have a functional surveillance system, you won't be able to pick up these things on time, and your vaccines will probably be useless, because if you can identify something, you cannot vaccinate against it, right? So health system strengthening and other aspects are important too. Now, this Global Task Force on Cholera Control, it supports countries, and they have lots of good ideas which they have set out in the roadmap. I'll allow some of you to go and read about it, and you know, we can have discussions after the talk for those who already know about this. Another example is measles, and the reason I give measles is because measles was actually targeted for elimination by now. Measles had to have been eliminated by now, and you can't believe that. If you look at the news and look at the statistics and the data from all over the world, measles is not going to be eliminated by now, not by this year, not by next year, not by 3 years' time, because just the gaps in vaccine coverage are just so huge. And unfortunately, something whose incidence was dropping, as you can see with the curve, dropping so much and has such a huge rebound. It's just painful to see all the resources that have gone into this. But again, we as humans, we have ourselves to blame, and we can only look at the victims and, you know, do our best going forward. So there's lots of conditions that lead to measles outbreaks. Vaccine gaps is one of them, but there's other reasons for that. But I won't dwell on that. You can follow the link at the bottom and see what warnings global organizations such as the WHO are putting out there. So how do you summarize all of this in terms of pandemic preparedness, prevention, and response? A global coordination is required, right? Because for those who can remember or who have read about it, when the SARS outbreak occurred, it spread widely, and there was probably very little global coordination. And in hindsight, after the epidemic, people realized that, you know what, we could have done better if we had coordinated our efforts. Everybody was doing their own show. Now, the WHO is there and is trying to coordinate global efforts with all the partners, and they're doing more or less a good job at it. So the good thing is that most public health specialists you talk to would recognize the need for this global collaboration, and many of them recognize WHO as an authority in terms of global health. And that is a good thing, because that's the first thing, for people to get together. The more heads, the better ideas can come out of it. So there's a financial intermediary fund for pandemic prevention, preparedness, and response that was established last year, and it's hosted by the World Bank, but the technical leadership is provided by the WHO. You can go to the WHO website, or you can Google it and read about what it entails. Basically, it provides a platform for advocacy, gives long-term financial resources, investments, and technical support, coordinating of partners. Because if you can remember, there's very many partners. Let's just say in Cameroon, this is a town hall for Cameroon, right? So the partners in public health are many. There's WHO, there's Africa CDC, there's the US CDC, there's many NGOs and other organizations like Doctors Without Borders and all of that have a huge role in these things. But everybody cannot run their own show. That will be total anarchy, so coordination is required, and many people recognize that. However, some barriers we can cite in terms of barriers to pandemic prevention is human activity. The people who are environmental activists will talk a lot about deforestation and all of that, but also in the healthcare sector, we have to be concerned, because as people impede into forest and other places, they're going to get into contact with more animals that can be reservoirs. But apart from that, we don't need to get to the forest. Just hosting animal farming, like pigs and chicken, those are potential hosts for deadly diseases. So human activity changes the exposure dynamics, Concurrent emergencies also happen, like I showed you the dashboard with the emergencies that are listed there. There's emergencies all over the world: earthquakes, floods, war, lightning, tornadoes, tsunamis. There's a lot of things that can, those are emergencies on their own. And if you remember the huge cholera outbreak that happened in Haiti, it came after a huge earthquake. So these things are interlinked, health cannot be a silo on its own. I can hear somebody's microphone. Is it a question they're about to ask, or what? Or should I continue? Okay, thank you. Now, misinformation is probably the most recent and one of the most fast-growing barriers to pandemic response. In fact, it's an epidemic on its own. It's a pandemic on its own, misinformation. And a certain statement was put out by the stakeholders you see, the WHO, the UN, UNICEF, UNDP, UNESCO, UNH, about infodemic. And it is really mind-boggling to see what happened during the COVID-19 pandemic with all the information that was put out there. And the worst part of it is that many of this information is put out there without any single backing, no backing source, no backing reference, nothing. People just put things out there, and now they introduce themselves as Dr. This, or somebody's playing with my slides, as Dr. This or Professor This, and they make a blank statement and it goes viral on social media, and you see things happen. So this is a challenge that we have to recognize as healthcare professionals going forward. It's not something we can push aside anymore. We all have to be more aware of how this information gets spread on social media and how to deal with it, because you don't deal with it by arguing, right? If somebody's arguing with you and say, today is the 1st of January, 2030, you don't win the argument by shouting back at the person that, no, it's not. You simply calmly explain to the person, why are you saying this? Show me where you got this information from, and show the person your own information because we don't have the gold truth, right? We don't have the absolute truth. So we are saying what we say based on the science we know. The science we know today can change. So we need to engage. All of us need to be social media activists. You can start with LinkedIn, which is like a professional social media tool, but you can go to Facebook, Instagram, and the rest. You all need to start speaking and talking about your fields and talking facts with resource, with valid sources. You know, you can't go and take a paper that was retracted or a paper that is of doubtful quality. So this is a threat that is facing all of us, you know, and COVID is just revealing the magnitude, but it was there before. You know, for those of you who have worked on measles vaccination campaigns, polio vaccination campaigns, you know that this is a truth that has been there for long, but it's a danger that was, I can say it was neglected, you know, it was underestimated. And now we saw what happened during the COVID pandemic. Now, inequity is another huge thing. All of us saw what happens with the outbreak or with the pandemic, you know. And this graph you see is a model that showed the percentage of deaths that could be prevented. Averted means prevented. Now, there's two scenarios only. What actually happened was that the high-income countries, they grabbed all the vaccines, basically. They grabbed all the vaccines. That is a simple truth, right? And then after they started making handouts to the lower-income countries after they, you know. So that scenario could prevent 33% of deaths, let's put it that way, like the graph shows. Now, if vaccines were distributed according to the country's population, we have the second scenario, which has about half. So about half of the deaths could have been averted in terms of percentage. So inequity is a real thing. The monkeypox vaccine was developed, you know, and lots of resources were put to it when it became an epidemic, or I don't know if you can say pandemic, because it was in many countries around the world, because it spilled out of, you know, sub-Saharan Africa. So this inequity is real. If everybody had the same resources, or not the same resources, but everybody used the same resources, because it's not only about the high-income countries, it's about how the low-income countries manage their funds. What funds are spent on healthcare? What funds end up in people's private pockets, you know? So these are all things that happen, and we have to say it, you know, but they have impacts on people's lives. The inequity leads to deaths that could be prevented. And this is just an example regarding COVID-19 vaccines. Now, the other thing is competing priorities, right? Now you're talking about antibiotic resistance. This has been there for long. You know, you've heard about the dangers of methicillin-resistant staphylococcus, right? So that there's many other multi-resistant pathogens. I don't know any of you have heard about what they call Candida auris. You know, it's a fungal infection. And it's also, you know, very resistant to many treatments. There's food insecurity, which is another pandemic. You can't be talking about vaccines when people don't have food to eat. How do people get vaccines when they don't have food to eat? The vaccine can save your life in a couple of days or weeks, but the food, if you're hungry, you die in a few days, you know. And it's a threat that has to be recognized. Now, chemical exposures are something that is mostly swept under the rug in most sub-Saharan countries. You know, people don't really pay attention just because maybe there's bigger problems. But these are things that happen, right? There's lots of chemicals and toxins that we and our children are exposed to every day. And, you know, nobody's really paying much attention to that. And we have to, apart from alcohol anyway, ethanol, by the way, is alcohol for those who didn't know, but we can see the consequences on month end, on Fridays and Saturdays after payday, what it has as immediate consequences. But there's other things that have long-term effects, like the pesticides in the foods that people eat, you know, and in the paints, the lead in the paints, and many other chemicals. Then substance abuse, which has become a huge problem. It was a huge problem already in high-income countries, but it's getting into our societies. If you follow the news in Cameroon, what's happening, drugs among the youth is becoming an epidemic. It is an epidemic. Maybe it is just an epidemic which is poorly described because there's poor surveillance for drug addiction. Maybe that's an idea for those of you based in Cameroon. You can start a surveillance program for drug addiction. You never know. But it's a problem. It is a big problem, and the consequences are seen. So in conclusion, right, you don't need a very deadly disease like Ebola to be a pandemic. COVID-19 became a pandemic. It has a very low case fatality ratio. The official figures are about 2 point something, whatever, but I think it is far less because many people have asymptomatic infections and never get tested, right? You need functional disease surveillance systems in order to early detect outbreaks and, you know, respond to them. If you don't set up a system to look for something, when that thing is there, nobody can recognize it, right? That is why it is important for these programs to be functional, and they should be there all the time. It's not only when there's a pandemic that people know that, oh, there's public health experts, there's surveillance officers that have to do work. No, in the absence of outbreaks, in the absence of pandemics, you need to make sure that these teams are set up and functioning properly, so that when there is an occurrence, the team is ready to run. It's not when there's something that happens now, people start looking for budgets to allocate to the surveillance team to set up surveillance or to reinforce surveillance. It doesn't make any sense at all. Now you need proactive risk communication and community engagement, right? Yeah, and you don't need to wait for the epidemic to happen before you do it. Like I said, all of you have to become social media activists, because it's important to start talking about these things and let people know that, this is what is happening. This is the latest advancements in science. You can now develop a vaccine within a shorter period. This is why you do it, but you don't do it for all conditions, because all conditions don't have the same priority, right? You don't need to rush within 12 months to develop a vaccine for, a condition that is not really having very high spread or very high mortality. Now you all need a multidisciplinary and holistic approach to tackling epidemics. You don't need only epidemiologists like myself and public health experts and other things to respond. You need logisticians, for example. You saw in the video when we were preparing to go to respond to the first case, that whole thing was arranged within 2 or 3 hours. And I had to catch a flight with all my PPE, all my information, all my tools I needed. You need to talk about information technology. You need to talk about, risk communication. So you need communication specialists, not journalists. Unfortunately, in Cameroon, many people seem to think that a journalist is a specialist in communication. Those are not exactly the same thing. And you need many other things. You need your politicians, your stakeholders, because they make the decisions. You need the finance people who give the money. So all these things are needed in order to respond. And so at this point, I will stop and I'll allow you to ask your questions and we can carry on with the discussion. Thank you very much.
Wow. Thank you very much, Dr. Villain. This is an excellent presentation. Brian, what do you think about the presentation? I really, really have been keen on it, and I think it's thrilling.
Yeah, I think thanks a lot, Dr. Motaze. I think that's a really great and
you can call me Villian. It's okay. Just call me Villian.
Okay. Yeah, I think it was a really great presentation, and he covered a lot of very salient points. But before we continue, I just wanted to quickly recognize the presence of Professor Shea Wisonge, and also the presence of Professor Dr. George Alemji as well. Dr. George Alemji has really been done a lot of work on laboratory surveillance. So he brings a lot of really needed expertise in this area of testing in particular, and how that capacity can be strengthened in Africa. And Dr. Wisonge has been a really an important voice on the subject of vaccine equity. And I love, Dr. Motaze, that you brought up this subject of equity, which is, I would say, it's a conversation that we don't have a lot. I mean, as physicians, we are used to prescribing medications for patients, but sometimes we don't think about the fact whether or not those patients can actually afford the treatment that we're prescribing for them. Do they live in areas where they have access to healthcare? Do they live within a distance? We're talking about outbreaks, contact tracing. So even when we reach out to community members and we ask them to isolate, do they have the resources to really even sit at home, right, and isolate for 5 days or 10 days? Are they able to do that? So I think that conversation around equity is so important, and it's something that we don't think a lot about. I just wanted to maybe, Dr. Motaze, give you a few minutes to take a break. Why? I just want to invite Dr. Wisonge. I don't know if he's able to unmute himself and maybe share a little bit of insight and wisdom here about his experiences and some of the things that I'm curious, Dr. Wisonge. What are some of the things? What are some of the things that we know we know today in 2023 that we didn't know when this pandemic started in 2020? What are some things that have dramatically changed? And I'd really love to hear your thoughts around that and some of your lessons and experiences on vaccine equity and how all of this comes together.
Thank you so much, Brian. I think Vivian has already said everything, actually, essentially, I think. Even though we had always expected that the pandemic would come, but when it did come, we found ourselves unprepared. Even though we've learned quite a lot, if you take the case of vaccines that you talked about, we are able to fast track clinical development, and new platforms came up that where we were able to register vaccines for the first time on platforms that had not been used before. So I think those are some of the lessons that we've learned, and of course, misinformation and disinformation that Villian talked about. This pandemic taught us the importance of vaccines, and also showing that vaccines, as important as they are not the only tool. We need to, a lot of time, always have been multi-sectoral approach and use multi-pronged approach, use every tool in our arsenal, and also ensure that the right information goes out there. And that us as public health professionals, we don't need to be passive about these things. We need to be active, sharing the right information and countering misinformation. So maybe those would be some of the things I would say, but I think I'm looking forward to hearing from all of you too, and thank you to Villian for a very great presentation, and of course, the organizers of this forum. Thank you.
Yeah, thanks a lot, Prof, for those comments, and it's always a great honor to have you here and to share your wisdom, and thanks a lot for your experiences and your advocacy for vaccine equity and the importance to build that capacity in Africa. We're very been a really great follower of your work, and I really have a lot of admiration for what you've done. I'm wondering if Professor Alemdri is on as well. I just wanted to maybe give him a few minutes to make a few comments about pandemic preparedness in general, and what are some what are some things that we know today that we didn't know 3 years ago, and how can we, prepare for the future? In the meantime, I would like anyone who has questions, you can either use the chat or you can raise your hand, and then I'll try to call you there. Professor Alemdri.
Yeah, good afternoon, and thank you so much for giving me the opportunity to comment on this. Happy New Year to everyone. So exciting that we've kept this relay forum going over the past couple of years, and it's doing so well. And the most exciting is for me to join the group again. I've been absent for a while. I'm so excited to see my own student, my son, William, today presenting. I always feel so excited seeing all of you with one of my students from the Faculty of Medicine really taking this to another level. It's been a while that we've been talking about pandemics and going around, but I think the way William presents it today is the way we should be looking at it, because you're really taking us across the continent. And I was so excited with your very first slide that really telling us the magnitude of the problem, because sometimes we tend to minimize. I know your data. And maybe an environment, just don't bother about the little noise behind, but your data, even though I think it went up to 2018, but just imagine what has happened within the last 4 years, including COVID and so on. It's a lot that has happened. And I like the way that you really put a lot of emphasis on things like the surveillance system. We need that to be up and running for us to pick up the pandemic as it evolves. But I think if we want to say what is innovative and what is new that we need to know, you did mention that in a copy of your slide, the sort of lessons that we learned, particularly for the COVID pandemic that changed the world, and it taught us a lot. And it said it affects the entire world in different spheres and different approaches on how we can address them. And I think one of those things that we learn in Africa is how do we prepare for the next pandemic? We saw that even in terms of the diagnostic, I think that is one area that we need to pay a lot of attention. We've seen a lot of improvement in terms of health system strengthening, in terms of getting more of our field epidemiologists and the laboratory experts being trained. But we saw challenges, particularly in terms of our supply systems, that we in Africa at some point, we thought we were ready for the pandemic, but we had all the innovation, all the machines were there. But when this pandemic hit, there was supply chain issue. We had a machine, but we could not test for the pandemic because the consumables are all produced in China or in the United States, and they have to be shipped to Africa. There was flight restriction, there was lockdown, there was everything. There was decentralization to the community and so on. So there is a lot that we've learned most with the new pandemics, particularly the need for us to begin to decentralize and focus in our community approaches, building more capacity, getting the governments involved. I think we'll learn a lot from the African CDC really leading and getting the African continent move the COVID pandemic in one direction. And we're so excited. I think most of you would know about our own brother, who is now Ambassador Nkengasong, who was the director of African CDC. He changed the public health the figure of public health approach in the entire continent, and the government sees as they own it. So he is now also now the current ambassador for the US, the Global Health Program, the PEPFAR program, which you know. And I think he's trying to use that same approach. So as we talk about this, I think leadership, particularly he defines things like sustainability to be seen in terms of political sustainability, programmatic sustainability, and financial. So we have to take it to that level where the governments always see that they own the program. And then most importantly, now we have this conversation around local manufacturing. There's a really need for us in the continent, not just think about continuous procurement or commodity from abroad, but let us be local capacity in the continent for all our supplies, consumables, the reagents themselves, and all what we need. And we'll continue to strengthen the surveillance system, just as William put it. So with that, I really thank you so much, and we look forward to more discussions on this. Over.
Yeah, thanks a lot. Thanks a lot, Professor Lendre, and it's really a deep honor to have you today. I really appreciate the comments that you made, the importance of countries taking ownership of the problem, and the importance of political will and commitment. I think Dr. Nkengasong really exemplified that during his tenure as the director of the Africa CDC, and he has really been a really great example and a really great model of how this approach can be useful as we think, as we go into the future, and as we think about future pandemics and things. So I think I'm going to take some questions from the audience, and we'll just have a Q&A. I'll just kick off with some of the questions. Kick off with the first question. And
before you give your question, because then when you start your question, we just allow our audience to speak without interruption. I just wanted to once again mention that William made a very great presentation, and one of the things as I listened to his presentation, I thought about the importance of also Africa building a very strong and robust clinical trial in infrastructure, because as you're fighting to contain the pandemic, when the pandemic is completely there, clinical trials need to start going on, and a lot of discoveries have to be made. So there is also a need to strengthen the clinical trial infrastructure. And I'm very glad that William has that capacity also in this domain, because I'm opportune to serve with him as a consultant with the Bill and Melinda Gates Foundation. And actually, he's a subject matter expert on just how to design, analyze, and communicate in clinical trials. And I think that's a very important aspect, which if anybody wants to do a presentation on how we can also strengthen our clinical trial infrastructure in Africa, that will be a very important segue to this topic for today. So over to you, Brian, for the Q&A.
Yeah, thanks a lot. I think clinical trials are really critically important, and I think that has to be I think that system has to be strengthened in particularly in Africa. I think what the United Kingdom did with the recovery trial and dexamethasone, which was really a life-changing therapeutic eventually, was just amazing. And I think that having those kinds of infrastructures is really critical moving forward. But Dr. Motaze, I just wanted to start us off with the first question. And I'm really curious, and I really wanted to hear your thoughts around what are some things that you think we are lagging behind in terms of pandemic preparedness. I'm curious about the experiences of the National Institute of Communicable Diseases in South Africa. What are some of the lessons that you have learned through the pandemic? I wonder if you could talk a little bit about some of the challenges and some of the experiences there. I saw the video where your team was deployed to do contact tracing. Do you think that's a challenge we still have in Africa? Do we lack field epidemiologists? Is that somewhere? I really want to hear more about what some key lessons that you guys have learned, and what are the things that you're probably considering what you're going to do differently as we move forward with the epidemic.
Thanks very much, Brian. Thanks. That's an excellent question. When I was presenting, I couldn't see the attendees, but I'm so happy to really see Professor Alemji talk. This forum, it also highlights again that this forum that was set up, this Cameroon Townhall is really a gold mine, and it's really wonderful to see, people you haven't talked to, people who trained you growing up as a young medical student, and to actually talk to hear Professor Wisonge speak. Professor Wisonge, who is my PhD supervisor and a mentor in many other ways. It's really wonderful. Thank you very much. So coming back to your question, one of the key things I would say is that Cameroon needs an independent public health agency, if I can call it that way, public health institute, basically, which is independent of, you can't actually say completely independent, because NICD is not completely independent of the Ministry of Health in South Africa, but NICD is the go-to institution as a whole that has its own way that functions specifically for epidemics, right? It is kind of a bit immune to the politics of ministries of health. Politics is part of every ministry, so it's no surprise that when it comes to ministries of health, there's some level of politics there. So it shouldn't surprise anybody. But in terms of the capacity of a country to respond quickly within a few hours of getting a result, getting a team on the ground the same day, at the other end with a team that is already on the ground waiting at the local level. There's a central level, there's in Cameroon, I would say regional level. And the people in the regions were made up of a combined team of people who are part of the NICD and people who are part of the Provincial Department of Health. So, but all of this initial response and a lot of the subsequent response was based on the activities and the recommendations by this almost independent body called the NICD. So I think Cameroon needs something like that, which should be very well established. And I think that is one thing that can really be a game changer in the way things go ahead. However, Cameroon is, the way they handled the pandemic was really good, because there was politics, but actions were taken, concrete actions were taken. Knowing the local realities, we can't expect them to do the same thing, like, for example, South Africa. But I think that it is already, they're doing a great job. The ministry has its own dedicated directorate that handles things like that, and that coordinates with the provincial delegates of health. But there's a need for that independent body that has a mandate to be mostly a technical body. This is immune to the politics, that gives their recommendations. And at the end of the day, because in every country, whether it's WHO or Africa CDC that wants to implement any program or support, the country has the final ownership, has the final say. But when the country is making that final say, they are making it based on rigorous recommendations that are evidence-based. Now, the other part, which is not evidence-based, is part of real life, the politics, the finances, and all of that. But at least nobody can say you didn't tell us, So that is the main thing I would say in response to your question. Thank you.
Thanks a lot, Dr. Motaze. I'll take the first question from LBG. Not sure. LBG, you have the floor. Please make your question very short, and so we can go through as many as possible. Thanks.
All right, thank you. It's Lobga. Sorry, I used my initials. It looked a little bit cool. Yes, thank you, Villian, for that presentation. I think I should call my son something starting with the King, because the King facts are doing amazing outside Cameroon. We're really proud of you. My question comes to the preparedness and the slide where you said people don't really understand what has been done. You may feel like they've not really done enough, but you don't really understand, but they've tried their best. I'm going to talk about what's happening right now. You see, China tried to contain the virus and block their borders and all the measures, and there was protests and everything. And the moment they opened, we started seeing all these cases coming out. And now what we notice is the high-income countries are blocking their borders and controlling and all of that. But we in Africa, we still are not doing anything. We're not blocking our borders. And I'm just wondering, what are your thoughts on this? Because I believe it has politics to play a role in this, probably because they are our partners economically. But then the next thing we'll see is they'll start blocking our African countries from coming to the high-income countries. And that preparedness become unpreparedness. So from your own point of view, what do you really think? What are your thoughts, actually? And if anybody has anything to say, what do you think about that?
Before someone responds, sorry, this is Julian. Can I just add that the UK welcomes everyone? There's no restrictions in the UK. In fact, we've taken off masks in hospital and only recently started wearing them because it's winter and there's high rates of flu and COVID. But since maybe about March last year, there's been no restrictions getting into the UK.
Thanks for that contribution. So the question, love guys, is a complicated one you're asking, right? Because remember, like I said, the technicians need to give their evidence-based responses and recommendations. But there's other things that come into play. China had a zero COVID policy, right? That's why they had lots of lockdowns, and they were still having lockdowns, up till a few weeks ago. And they had to abandon the lockdowns, partly because of the protests, but you never know what other evidence came up, but we cannot really say. Now, in terms of blocking borders, the question we need to ask the people closing their borders is, what happened to the other measures? What happened to getting people who are fully vaccinated? Now is a political term. What happened to people who have had at least, say, 2 doses of vaccine, and people who had a negative test 24 to 48 hours before the flight? What happened to that? Why is closing of borders still an intervention? I'm not saying I'm in support of one part or the other, but in public health, for example, like I said, remember when I quoted the example of Jon Snow, everything starts with logic. If you have implemented measures in 2020 in the heat of the pandemic, and in 2021 when you started opening the borders a bit, why are you implementing different measures now? I'm not saying people don't have the right to protect their citizens. Locking the borders is actually a well-intended measure to protect your citizens. But now, when you are inconsistent in decisions, now people need to ask questions. And unfortunately, we are not in the platform to ask them those questions directly, but I will just put it out to you to think about it. What happened to the negative PCR test and the vaccine certificate or vaccination, proof of vaccination? What happened to that? Why are people closing the boundaries? So people can do whatever they want to do. It's their country. They can close the borders if they want. And unfortunately, there's nothing anybody can say about it, But I would just want to say it is a noble thing to aim for zero COVID cases. But my personal opinion is that 3 years into the pandemic, it doesn't make any sense to aim for zero cases. It doesn't make any sense to aim for zero cases. We know that, like I showed in the slide, the virus is mutating. There's new variants. If you have evidence that it's a new variant that escapes the immunity conferred by vaccines, that has a high probability of influencing the diagnostic test accuracy of currently available tests, then you can say, okay, we block the borders because we have a new variant that is a big danger. It's associated with higher morbidity, mortality, disease severity, and now we are not sure the vaccines really work. Now you can do things based on the evidence. So it is important to be consistent in what we do, and we should not give into panic and political, I don't know, reasons or interests that makes us decisions to be taken over.
Yeah, thanks, Motaze. I think that's a really fair point. We saw these travel restrictions throughout the COVID-19 pandemic and the impact that has had, and it's really unfortunate. It's really unfortunate. It's really unfortunate, the travel restrictions that were implemented, and Africa essentially being punished for example, the team in South Africa that led, the discovery of the Beta variant, for instance, the Omicron variant, and all those travel restrictions. And I think that was just a very disastrous approach. And I think from an epidemiological standpoint, the ability to quickly recognize when you have a transition from independent introduction to community transmissions has very important implications for how you respond to the pandemic. And I think that's more important rather than taking some really unnecessary political move. I want to give the floor now to Dr. Wingo. Dr. Wingo, over to you.
Yeah, thank you very much, Brian. And thank you. And I'm really impressed with the work that you guys are doing on the actions. Really to try to get some practical things and then to get some clarifications. So the first question is, before the 5th of March, what specific activities or program actions were in place in South Africa that permitted or enabled you to be able to catch that case? It's very important for us because as public health physicians, we know a certain number of things we should be doing. But what special things were you doing while waiting for that first case? That's my first question. My second question is, what is the relevance of equity in a context of vaccine hesitancy? Like, how should we approach that? Like, we want to be fair in the way we distribute vaccines. But what about the way hesitancy stepped in? How does it modify equity according to the way we are looking at it? Then my last question is going to be about predictive models for outbreaks. What's your experience with producing predictive models, probably for Ebola? I mean, a lot of work is being done around predicting when the next outbreak is going to come up. And is that something that we should actually promote? And is it very useful according to your own experience with researching around papers that have been published on that subject matter? So let me stop there for now. Thank you.
Yeah, over
thanks
to you.
very much.
I think those are great questions. Yeah.
Thank you very much, Ringo. Great to talk to you again after many years. I'll start with your last question. I think it is a completely useless exercise to sit developing a predictive model for when the next pandemic will occur. That's just, it's my personal opinion, it's a waste of time and resources and energy. I don't think anybody should fund something like that. We know they are going to occur, and we know what we need to do in order to mitigate their effect. You cannot prevent a pandemic per se, because it will happen. You can, if you prepare every country and every region within the country, every district. The district is the basic building block of the healthcare system in any country. If you prepare every district to respond adequately to their outbreaks, you will never get to the pandemic. So rather than spend time trying to predict, like people have already predicted when the next pandemic will be, that's celebrity epidemiology, which I am not a fan of, to be more polite. The second question I'll answer is, what were we doing in South Africa before that first case arrived? So South Africa has had several virtual simulation and some of the practical simulation exercises that were conducted. You know, for example, at the OR Tambo International Airport, there was a simulation of the importation of a case. And at the border, which is the first barrier that, okay, the virus or pathogen itself doesn't need a passport, but the human being needs a passport, right? The human being comes in. We did simulations on how do you manage a case like that, which is picked up at the airport. And there have been other simulations and trainings that happened for many years. In fact, since 2015, in the heat of the West African Ebola epidemic, there were lots of training activities that were done. And for many years after that, training was done regularly. There were lots of activities to strengthen the surveillance systems that were done because of local outbreaks. South Africa has had a number of measles outbreaks over the years. And at that time, when I was working at the NICD, I was in the Center for Vaccines and Immunology, which was the center in charge of measles, polio, hepatitis. So due to those outbreaks, we did lots of trainings and, you know, so you have to be prepared, right? You have to do preparatory activities in terms of specific preparatory activities like simulations that simulate a specific case like an outbreak, but your surveillance system has to be rigorous, you know, on an ongoing basis, and you have to question yourself. And the NICD does a lot of what we call surveillance system evaluations that are done by the FETP team, the Field Epidemiology Training Program, and they try to identify weaknesses in surveillance programs that can be strengthened. So that's a constant activity that has to be done. That is why when something like that happens, it's easy to put together a team and, you know, within a short space of time, people can be ready to hit the ground running. So those are some of the activities that were done. I hope that answers those two questions. Now, the second question you asked is a bit, I'm answering it at the end because I wasn't sure I really understand what you were asking for. Was it about the vaccine hesitancy and the impacts of that vaccine hesitancy on equity, for example, when it comes to vaccines? Am I right?
Yes, I think that's the spirit. Like we want to be fair in the way we distribute vaccines, but do we factor in the fact that many countries do not take these vaccines and they end up getting expired? That also is a problem.
Yeah, that's a big problem. You know, that's a big problem. Many high-income countries bought millions and millions of vaccines, and you know, some of these vaccines actually expired. You know, now the question will be when they were buying these vaccines, the producers, and is there any international? There are international bodies, right? That when we say the issue of equity, it doesn't mean nothing is being done. Something is being done, but I would like to emphasize that I don't think it's enough. I think there should be more oversight about these things. You cannot allow 5-6 countries to buy vaccines that can vaccinate the population 2 or 3 times over. It's not acceptable. At the same time, the people who make these vaccines are businesses. They are multinationals. These are businesses, and they run as a business. So one of the participants whose hand is up might probably give some insights. That's Dr. Manji Enshaw, who worked for CEPI for some time. So there is a global initiative to actually try to address these inequities, but I just think it's not happening fast enough. And the biggest fear, my biggest fear, is that the next pandemic can arrive when the same thing can happen, and Africa will not probably get away with it as we got away with it, because obviously COVID doesn't have a higher mortality, and we have other things that have a lot higher mortality. So I think it is the issue of hesitancy should be addressed by health professionals and the public health experts to address it and engage with the communities on a constant basis. But I don't think that should be taken into account at all when people are buying vaccines. If Cameroon wants to buy 30 million vaccines, and we know that there's a high vaccine hesitancy sentiment, they shouldn't factor that, because it's something you cannot predict. There are people who can post online, they will not take the vaccine. When they see their neighbor die, the whole neighborhood is going to take the vaccine. So you cannot use that. I think it should not be used as a measure at all. I hope that answers your question. Thank you.
Yeah, thanks. I think those are really great comments. I just wanted to make a really brief comment about his first question, which I think is really critically important. That, you know, when you have a first case, what do you do? And it's very important to recognize that most of the cases we see in the clinics and in the hospital is really just a tiny fraction of what's happening in the community. Really what the realities in the field. And we probably have to figure out and think about better infectious disease models that can really better predict. I think Dr. Wingo's questions are really very, very pertinent and really very important. How do we develop infectious disease models that can really help us identify community level transmission that's unseen? I think through COVID-19, we did see that a lot of transmission was happening from people who were mostly asymptomatic, driving the chains of transmission. And sometimes people are, maybe sick and not feel sick enough to go to the hospital. So obviously we won't have those cases captured within local and regional disease surveillance mechanisms. So we miss on some of those cases. People who are symptomatic, there are people who may be ill but not have the resources to go to a local hospital or to a clinic to go get tested. So those cases, again, are missed in our disease surveillance systems, and we need to identify those cases in order to do contact tracing. And I think the point you made about field epidemiology training programs is really critical to deploy those individuals into the field to do contact tracing. So I think that's a really, really fair point. And this conversation around health equity and how do we increase access is really very, very pertinent. And thanks a lot, Dr. Motaze, for making those comments.
So Brian, quickly before you go to the next person, let me just, maybe I misunderstood Wingo's question because I thought he was talking about models to predict the next pandemic. If it's talking about models to describe community level transmission, there were more than enough models that did that, Models are based on assumptions, and sometimes you can give a range of values to these assumptions. You can say, let's assume that 10% of COVID cases are symptomatic. And depending on who built the model, you can build into your model that about 90% of cases are symptomatic if you want. And many of these models were put out there and they were executed. But in order not to belabor the point about modeling, maybe that's a topic for another town hall. But models are not there to predict the number of cases, right? A good model in epidemiology, which is probably a transmission dynamics model, is there to just give you an idea of the dynamics, how the disease is spreading, in the community. That's a broad statement, but we don't need to unpack it. It's to say, if you have 5 interventions that you want to implement, which intervention is likely going to have the highest impact? The exact quantification of that impact in your output of your model is not important, because most of the time, your model is an ideal world. It's happening on a computer, right? You cannot predict many things that happen in real life, but there was no shortage of models. If one thing that happened during this pandemic is there was too many models, there were just too many, and now people just get confused when there's too many models. Again, we need to go back to our core institutions that should be the go-to people when we talk about things like mathematical modeling, because it's a new field that has grown, but it's a field that can be very misleading. One of the most famous people, if you attend any mathematical modeling course, there's a slide they will most likely show you, and those of you who have attended can testify. There's a slide that always says all models are wrong, but some are useful. And it's not to put models in a negative light, it's just to highlight the fact that you shouldn't follow the outputs of a model blindly. It's meant to be useful in the context of you understanding the real world situation. But yeah, we can go next to the next question.
Yeah, I completely agree. Dr. Manzi.
Yes. Hello, everyone. I don't think I'm asking a question. I'll be asking a question. Instead, talk a little bit more on an aspect we just made mention about strengthening the ecosystem of clinical research in Africa. And one thing we've learned for COVID about health equity or health security, it all comes back to how do we make sure the ecosystem in Africa gets strengthened. And I think one thing, I don't want to repeat what has been said, but I think one thing that was, maybe we are taking it lightly, is the private sector. You see so many organizations coming up right now, they are still putting in about, it should be, government should lead these initiatives. But look at what happened during COVID, and look at what happened in the Western world. If we didn't have Moderna, we didn't have Pfizer, we didn't have BioNTech, we didn't have all those institutions, would have had a very big challenge to have that technology to be able to be useful for COVID. So I don't want us to forget or undermine the private sector that is still very, very low in Africa. If we really want to talk about being strong in Africa, we have to upgrade our private sector, be it in the supplies, the consumables, the intellect, everything has to come into play, and that shouldn't be undermined. So this comes to the point I want to make, that we have been able at the moment now, and I'm talking, my brother was here in Rwanda when we showed him, Dr. Villen, about the African Coalition of Clinical Research or Contract Research Organizations. That is just something that we have created. A group of contract research organizations in Africa have come together and take it into our own, as ourselves, of a mandate to put such an office in Rwanda in Africa, just to bring other people together. And the other point I want to make, yes, COVID has showed these opportunities, but there's one key thing that is right now, or even before COVID, maybe Ebola, these clinical research organizations, or even our institutions, go back to the universities, we work in silos most of the time. I will tell you, yeah, there are coalitions, there are factions, Africa CDC is coming up right now, but I think we still have to push for collaboration, collaborative efforts, bringing in the private sector, bringing in the public health sector, the public sector, bringing in the communities. So I think that's one key way we need to move forward. I just bring an example, just take an example, how many of our PhD discoveries have been burnt? If you go back to your university right now and look about your thesis, where is it kept, where are those discoveries? So there's even a big gap between discoveries in those big institutions in the university and what gets into the market, what gets into doing clinical trials, preclinical trials, clinical trials. So I think there's also a big gap. Our universities, our research institutions are not linking up with those companies or those industries as well enough. And that's an area we need to learn from COVID, that had it been those two refugees, Turkish refugees that were researchers in Germany, and they were working in their own small lab, I'm talking of Pfizer and BioNTech, right? BioNTech specifically. If that was not being done and being given them the opportunity to do so, and the Pfizer coming in to help BioNTech in that support, would have had a little bit more time to get that vaccine on the line. So I really want to stress on the efforts about the private sector, and they should be supported in and how we prepare to make sure that the ecosystem is being strengthened in Africa. I will stop there.
Yeah, thanks a lot, Dr. Manzi. And Dr. Motaze, do you have any comments on that?
Oh, I'll just come in briefly. Thanks very much, Dr. Manzi. It was a pleasure to meet you. And I think this is something that many people in this, I've had a similar conversation with Dr. Muno. We need to prepare the ground in terms of clinical research, which means that I'm sure, I don't know all the people in the audience, but I know a lot of people, my classmates in medical school are now lecturers in universities. And one thing I always tell them is that you have the lecturers who are clinically focused people. And if you look at the way research was done in our medical school where we're trained, there's many people who are clinically strong, but in terms of research methodology, they could get some help from the specialists in research methodology and epidemiologists and all of that. And we need to work together. Many a time have I offered my services and say free of charge, if you have any research project you want to carry out, contact me, I'll give you free methodological advice. I have also done so via the Center for the Development of Best Practices in Health and Yaoundé Central Hospital, where we propose services. It's a group of researchers. And that is how we lay the groundwork. I am not a strong clinician right now because I haven't consulted a patient in years, right, since I moved into research. In the same light, clinicians need to recognize that unless you go and undertake a specific training, it's hard to build a really strong research-focused institution, and there's an ample room for that. So I think we just need to work together, and if platforms like this can make us get together, know each other, and start working on concrete projects, then the better. Then regarding the private sector, as Henshaw mentioned, in terms of intellectual property and all of that, it's a mile that we have to go intellectually, like literally speaking, because we are not doing anything with that. And if you want to move it forward, you have to start somewhere, right? There's many partnerships that are available. There's a lot of funding that is available for research capacity development, but it is important that there is a coordinated effort again. There should be a coordinated effort, whether it's at the level of the medical school, whether it's at the level of the ministry, whether it's at the level of a dedicated independent body to coordinate these efforts. Because if these efforts are not coordinated, people end up doing their own individual projects. And when it happens like that, at the end of the day, somebody's main focus is to pay their bills and put food on their table, which means that at the end of the day, the whole glamorous idea of pushing research forward in Cameroon, for example, might actually, be diverted towards somebody's carrying out research just to make sure that they are paid their bills. So these things have to be coordinated. These things didn't happen by chance in these developed countries. All these big pharma companies, if you go and find out about their history, they didn't start off aiming to be international pharma companies. They started with a specific objective and they worked and they built up over time. And you cannot skip steps. If you want to develop something like that in Africa or in Cameroon, you must do your due diligence. You must take your baby steps and learn and grow. It takes time. It doesn't happen overnight. So I just really want to appreciate Manzi for the comments he made. Thank you.
Yeah, thanks, Dr. Manzi, Dr. Motaze and Manzi for really underscoring the importance of this international cooperation and coordinated approach towards this response. And there are people within the town hall here who are really good. I don't want to put him on the spotlight, but Dr. Kenji was really, and his group at Stanford University, were really one of the first people who led the develop, just coming up with new diagnostics. And I think it's really critical having the ability to sequence. We had a sequence for the first case of COVID, and that sequence was made available within a couple of days and made publicly available on the GISAID database, the Global Initiative for Sharing All Influenza Data. And I think that was very useful because from there you can find which areas of the genome is less conserved and can start developing diagnostic tools. And I think they're kind of really great experts here. But I think my wish is if we can talk with one another and really institutions, cross collaborations and cross cooperation and things like that, and countries talking to one another, I think that's really going to help, particularly in research development, in vaccines and therapeutics and diagnostics and things like that. So I think that's very important, and thanks a lot for making those comments. I don't know if Kenji is in the hall, but I really wanted to also hear about his experience with developing diagnostics almost in real time, and how they've been able to build that infrastructure at Stanford, and what are some lessons, I don't know, Kenji, what are some lessons that you learned in your experience that you think that would be very beneficial in Africa?
Yeah, thank you so much, Brian. Thanks, everybody. I think developing diagnostics, just within a few days when you have the sequence, you just need to have the expertise, right, to be able to, design the primers. Of course, you need to have the sequence available, especially if it's a new virus. But the challenge, for those that are in the lab is not just having the primers, right? You need the samples to be able to validate that assay. And we really had to be creative because at that time, there was no positive sample in the US. I think at that time it was just like one case or something like that. So we had to, engineer our positive controls, right? Like we just produced the gene blocks based upon the sequence of the virus. And that worked great for us. So we're able to use that. We did our dilution, did our lower limit of detection and all those things. Then when we start having positive samples, now we then did a clinical validation. So I think that's one of the things that we've really learned, that you don't really need to have the positive sample for you to be able to validate your assay. So you can try to get ahead of the curve, right, to validate that assay before you even have a positive sample. And I know one thing we've also really learned, as our prof said, is supply chain challenges, and all the like. It was not only in Africa, even in the US, we faced a lot of difficulties too in terms of supply chain and all the like. But I'm so happy that, You know, WHO, CDC, and a host of other partners are doing just a lot to make sequencing available. It is quite pricey when you talk of Illumina sequencing technology, but now I think WHO is promoting a lot of Oxford Nanopore. So you just have like a small sequencer, like an iPad, right? That you can travel with it to the field. I'm going to Ghana next week to train African scientists on that. So it is just so great that something like next generation sequencing, where we used to look at it as an illusion, right? When I was in Cameroon, now it's becoming so accessible in such a way that you even have some that, you know, are like mobile phones. So I think that with time, some of these technologies that we used to look at it as very, very expensive, is now becoming very affordable. And the good thing I love so much about African scientists is that they are very, very brilliant. What we need are just the tools. In terms of the knowledge, we have the knowledge. It's just to give the tools to them, and we'll be able to, you know, do better. So I think we are better prepared now, you know, as compared to a long time ago. We have a lot of PCR machines that are dotted all over the place. I was looking at the EQAQ data, you know, from Africa and all the like for COVID and influenza, and it looks good. The labs are doing very well in terms of WHO external quality control. So that really gives us some assurance that the technicians really know what they are doing, and they just need more tools. Over, please.
Yeah, thanks a lot, Kenji, for those comments, and thanks a lot for all the work that you've really done at your institution. It's really great. I think that the advances in next generation sequencing is truly changing the landscape of infectious disease surveillance. Sequencing, the availability of genomic sequences is giving us the opportunity to address a range of epidemiologically relevant questions as well. And I'm really excited about the future of genomic surveillance and how we can use that data in real time, and merge that data with clinical data, merge that data with case investigation data, and really respond to outbreak really quickly. Malabo, if you can unmute yourself.
Maluba, not Malabo. Yeah, thank you, Dr. Tegobo, for this opportunity. And I wish to thank everyone in this forum for bringing this great initiative, not forgetting my mentor, Mr. Darcy Evans. Yeah, I think it was a great presentation, Dr. Motaze, if I'm right. Yeah, but my question is, after the COVID pandemic, Cameroon went through a lot. We call it a success in Cameroon because we did not get high mortality, and many things were actually implicated in this process in Cameroon, where we got many different jobs from CLEDA, for many different people. From all these experiences, what platform has Cameroon taken into consideration all these different initiatives that may have helped or maybe to reduce the death rate in terms of COVID? What platform has Cameroon created in terms of surveillance, diagnosis, treatment, that if in case there's another outbreak, they will try to put this in place to effectively control the pandemic? Secondly, if in case there's an outbreak of COVID again in Cameroon, and we are talking about chain supply, if in case this chain are still breached where borders are closed, how prepared is Cameroon for another pandemic? Like today, if in case they say that the borders are closed, how prepared is Cameroon? What have Cameroon learned from this COVID stuff, especially? What is the way forward? What are they thinking? Because sometimes we always say it was successful. What is there if there's another pandemic today, sincerely? Thank you.
Okay, thank you. Thank you for the question. So what I would say is that maybe somebody who is at the Ministry of Health in Cameroon can maybe add some context and respond better to your question. But what I would say is that Cameroon maximize their current available resources. That's what I can tell you. They maximize their current potential, technical potential, financial potential, and I'm not going to get into the all the drama that happened around all the financial misappropriation. It's not new. I can't say it didn't happen. It probably happened. But we'll let the people who are in the domains of justice follow that up. But in terms of stopping the borders, if you say Cameroon has to close the borders, Cameroon has a very difficult border to close.
Many countries have, in fact, if you share a long land border, unless you build a gigantic wall that has 24-hour CCTV surveillance and all of that, it is possible for things to get in. You don't even need only that. There's still people within the country, because if you close the borders, then the prices of things go up, right? So people can get things inside. South Africa banned, for example, the sale of alcohol in the first phase of the lockdown. I can tell you that I know people who could get alcohol if they wanted to. They know who to call. So Cameroon is not the only one in that situation. However, closing the border usually is not the only solution. It's one of them. Cameroon has a border security force. You know, the customs is the border security.
My border here was not meant like the border per se. My border was in terms like, if in case, let me say there's another pandemic today, what can Cameroon do in order to make sure that maybe because we're lucky with COVID, even though we don't know why we succeeded, that people do not die a lot with COVID. If there's another imminent pandemic that is really mortal to the population of Cameroon, what platform do Cameroon have now that will reduce these cases? What do we have in place that have put after from the lesson we learned from COVID? Yeah,
your question doesn't apply only to Cameroon.
Yeah.
Remember COVID mortality, I've kept on saying that the official mortality, if you look at the deaths in terms of the cases, we're looking at a mortality of under 2%, right? And I was kept on saying it's actually lower. And if you look at those who died, it's people who are either elderly or have underlying diseases. Most of them. I'm not saying normal healthy people cannot die, they can die, but most of the deaths occurred in specific populations we know, which means your question is a valid question for Cameroon and it's valid for the entire world. If Cameroon has if you look at the population demographics of Cameroon, Cameroon doesn't have an aging population compared to, say, Italy, where there were lots of deaths, right? If you look at comorbidities in terms of cardiovascular disease, like obesity, morbid obesity, and all of that. I mean, if you look at the US, look around you, you probably see why there were lots of deaths there, you know. So I think the way, for example, earlier Ebola outbreaks were controlled, those, at that time, the mortality was close to 80%, right? 70% even. It was a military operation. They identified a cluster of cases, they shut down the whole area. Every country in the world faced with a disease that has an 80% mortality is likely going to do the same. Whether you are in the US or in the UK or whatever, if you have a disease with an 80% mortality and you identify a cluster, all countries, it becomes a military operation. And not because people's human rights are abused, but because if you tell people to stay at home, people don't listen. We all know people don't listen. So Cameroon will probably use all the resources available to react to any pandemic, depending on how intense it was, right? So malaria kills people every day. A child dies every 30 seconds of malaria in sub-Saharan, in the world anyway, not in sub-Saharan Africa, but there's millions of people that have malaria in sub-Saharan Africa, in Cameroon too. So, and these are mostly children under 5 years. So we have had many other challenges that ensure that that low mortality of COVID wasn't that high, and the measures taken, you know, had the effect that they took. I'm not the one of those who actually go out and really say it was a huge success and all of that, but I would say we maximized the resources we had and the mortality wasn't high. It wasn't as high as, for example, in Italy, in the US, in some countries in Southern America, in South America. So that's what I can say. I don't know what is cooking in the ministry, what they are preparing or what they're setting up, I don't know. We will see when they announce. They probably must be doing something. If they're not doing something, we will see when the next pandemic occurs. But I think you are asking a very important problem. And that is the same question I've asked in many people, many countries, because in my work as a WHO consultant, I've been to a number of countries to respond to pandemics. And I can tell you that there are many countries that haven't done much different from what Cameroon did, given similar magnitude of resources. Even countries that are high-income countries, some of them, if I can put it that way, because all countries have competing priorities. But I will leave it at that for now. Thank you so much for your question.
Yeah, I just want to invite some
comment on the question.
Yeah, I was just about to invite you, but yeah, thanks.
Okay. Yeah, so let me just comment. Thank you so much. I think one thing that we may have to learn, and that is the way the conversation is going, is for us to begin to look at how the African continent look at pandemic preparedness and response as a continental issue, right? We don't want to only go silo. If we want to go silo, there may be a lot of issues. But if you look at the way the continent, we can take example of what I talk about with the way the African CDC was a rallying force for the continent that is sat there in Ethiopia, was able to pull resources together, started by providing training to the different laboratories and get them that got the government together to start developing the supply chain systems. Please, just 1 minute. Let me stop. Sorry, I'm inserting. So I just wanted to say that the only way that we can get this resolved is for us to look at the way the African CDC got it right for us, putting all the continental governments together, addressing supply chain, getting vaccines for the continent, working through I think the Afrexim Bank and the African Development Bank, getting that sort of the big picture. But most importantly, remember that the African CDC has set up these 5 regional public health institutes in Africa. I think there's one in Gabon for the West Central Africa. There's one in Nigeria. I think there is Zambia, and there's Egypt. And then they are also working with the government to set up the National Public Health Institute. These are really structures that they want to strengthen the surveillance system, the supply chain system, the data system, and make sure that they can have a sort of a continental response to outbreak, right? If you strengthen those 5 regional systems and they're also used to strengthen the national system, they'll be to see like we have a structure that one country or one region can assist another. We saw the benefits of the genomic sequencing. We saw what happened, but you can't expect that every country will have a genomic sequence system. But if you have that sort of a regional system that countries can use to assist other, that would be great. So let's look at it in that big picture to say, let's build strong surveillance and strong public health systems that can be leveraged to cut across the entire continent and support each other. The country approach is good, but as we talk about country, let's look at the regional and then the sub-regional and then the country approaches. So I just feel like let me contribute because that is where the entire continent is moving now. If you talk to the African CDC, you talk to us in the PEPFAR program, we are actually restructuring the PEPFAR public health system that was strengthened and making sure that we are moving in that direction. If you look at the continent, look at what was in Africa, let's say the 2013, 2014 Ebola, I was deployed to Guinea. There wasn't just anything in the continent to really address outbreak and so on. But beyond that, there was this strong regional corporations coming up and working with international partners like the CDC, the US, the PEPFAR that we work for, the Global Fund. And at this point, a lot of systems have been strengthened. So we have to continue to strengthen those systems, but make sure those systems are sustainable. Get the governments to lead, as I said earlier, the government leadership is very, very important. And they need also to recognize the regional bodies like the African CDC. Then there are also other the supply chain bodies and also about this local manufacturing that I mentioned before. So thank you so much.
Yeah, thanks a lot, Professor Lemdi, for those remarks. Those really critical comments, and thanks a lot. It's always great to hear from you. Joe Ekolo.
Yeah, hello everyone. Happy New Year once more. It's been a while. I want to commend your efforts for keeping this platform for the time that it has existed till today. To speak to my senior there, in fact, we've met in secondary school many years back. And I just want to ask a few questions. And here, I would say I'm not a doctor, I'm not in the medical field. I should state that in the very beginning. I'm just a civil, society member who is interested in the pandemic and also with a little background in psychology to understand the perception of, people when it comes to pandemic or illnesses. Like Dr. Kingafa mentioned here, the health practitioners cannot work in silos. You need to collaborate. We all agree on that. But the question I really have here is, we have struggled a lot with, the infodemics issues, that's misinformation and disinformation. And that brings us to the question of vaccine hesitancy. So my question here is, no matter how good we work, as scientists, as laboratory technicians or epidemiologists, people will still struggle to accept the fact that what science is giving us is good and it works. Because people are out there saying a lot of things about the vaccines, how soon it was made, how fake it is, or their trial and so on. But me being in this space, I get firsthand information from the scientists I believe and I trust in your work, but the population out there isn't getting access as much as we do here. So like we say, we cannot work in silos. What are the mechanisms that is being put in place by health professionals, not just to entrust the fact that you have a research, you've got your sources, to communication agents to explain what you do? How well do you integrate the psychological aspects of the community itself in, building your case for why you should go for a vaccine or why it takes this short time or the efficiency in what we do? So I am really much concerned about, the community psychology around illnesses and pandemics, such as the COVID-19. So that's my first question. The second question is, I understand, Dr. Kingafak is in South Africa. I was in South Africa myself throughout the pandemic, only came back early 2022. I'm currently in Cameroon. I want to understand how much did the HIV lessons inform the reactions or maybe actions taken during the pandemic, because we all know it is also built around perception, the struggle to eradicate or maybe eliminate, or reduce the impact of HIV. It was all built around the perception of what HIV is, the causes, the treatments. So what were the lessons that were learned from the HIV treatment process and everything informed, in also communicating with the COVID situation? Thank you very much.
Thank you. Thank you so much. Good to see you again after many years. I'll start with your first question. So when I talk about, you talk about community perception, right, which has a direct link to the vaccine hesitancy sentiments. That's why I said to you in my talk that all of you need to become social media advocates, because people need to understand the work you do on malaria, on TB, on dengue, on cholera, and you have to. Maybe there might be organizations who deal with health communication in Cameroon, or if you can contact somebody through your networks, that can help you find a way to simplify the message, because publishing papers is good. Most of the things we share is our links to our publications, but nobody reads that. Even your scientific colleagues and doctors will read the abstract if they are kind. So in your social media, you need to come up with a narrative to say what you do, right? And how is this important for people's health and how good your science is. If people trust you that you have been working in different things, then they will trust you when you talk to them about COVID. The problem about COVID is that many people don't talk about their science. They don't talk about their research. So when somebody posts a video on Facebook saying, I'm Dr. This, vaccines are a gene therapy experiment that will whatever, people will believe them because people are not being used to any narrative. They don't have anything else to listen to. They don't read our papers, right? So that is one thing. So that's why I said the engagement has to be continuous on your social media. Don't only post when you're on the beach, right? Have a discussion so that if people follow you, people should have a reason to follow you. Liking your pictures on the beach is one good thing, but people should be able to know that this is a researcher, this is a medical doctor who does open heart surgery or who treats people with stroke or whatever, and they understand what you're saying, so that the next time they enter a bus and somebody shows them one leaf and that leaf cures 1,000 diseases, they are skeptical. But the only discourse that usually happens in the public is people who climb on buses or these radio stations of these people who show their own different remedies. That's why they have a huge following. So we in health, we are always thinking that our science and our publications and whatever, they are good. They should be good for a specific audience. But that audience cannot be the local person who is looking at your Facebook profile and who is going to screenshot it and share. So that is the solution. It has to be an ongoing thing. I myself, I must admit, I need to do better at that. So it's not like I'm saying that I've been doing it perfectly. I need to improve on that too. But people need to understand that it is important, because when the pandemics come, that is the fertile ground on which your words will sprout, right? So it's important. Regarding your second question on the lessons from HIV, I don't think I can really say there were some specific lessons from HIV that were learned in order to respond to the pandemic in South Africa, because the HIV pandemic was different. Of course, you are right by saying the way the information was accepted and the way the information was not accepted, it was dealt with, had a big impact. But the social media misinformation campaign didn't really exist in the terms of HIV. So it is one way that was taken. There was actually an entire department for communicating about the pandemic that was put in place by the incident management team in South Africa in order to give people as much information as they can, as much accurate information, communicate, interview the scientists, get them to speak in simple language. They have a social media post on Facebook, on Instagram, on LinkedIn, and Twitter, just to put out information. That's how they handled it. And that, of course, is recognizing what happened during the HIV pandemic. But of course, like I said, is recognizing or is learning from the lessons of previous measles, diphtheria outbreaks that have happened in South Africa before. We even had IVDVP cases. You know, if you know what IVDPV is, it's a huge thing. It's treated like a wild polio case, basically. So they learned more from these acute, more recent lessons. The mistakes the lessons were learned from HIV long time ago in the early 2000s latest, mid 2000s latest, and the entire way in which the government of South Africa approached management of HIV switched completely. I'm not going to go into the details of that because, you know, those who want to know about it can go and read about it and find out. But yeah, that is the lessons that they learned from this pandemic. Most of it was from more recent pandemics, more recent outbreaks, as opposed to learning from the HIV pandemic. Thank you.
Yeah, thanks a lot, Dr. Motaze. And we just have to round up. I think I'll just take a last set of questions. But I just wanted to point out one of the questions that was put in the chat by Dr. Asomba. I think it really has to do with surveillance, particularly for that data. It's really, I think it's a really pertinent point, particularly when we are thinking about outbreaks and as you alluded to early in your presentation, knowing the exact number of cases that we have in an outbreak is not everything. We really have to know what the population we are dealing with and what the numbers of births and deaths are within the population to have really accurate estimates of what the outbreak situation is in the local community. And I think one of the issues we had in Africa is, not really knowing exactly what those numbers are in terms of deaths. And I know that the, COVID-19 had, more severe outcomes in elderly people, but how do we have more accurate estimates of those numbers? And I think it's really a very pertinent thing. And I don't know what kind of surveillance mechanisms you have in South Africa. I was wondering if you could just briefly comment on that before I pass it on to the chair.
Okay, thank you. I think.
Hello, Brian.
Yeah, please go ahead. I'm not sure.
So I stopped because somebody was speaking. I'm not sure if the person wanted to respond or I should go ahead.
Yeah, you can go ahead.
Okay. So briefly, the surveillance system in South Africa are the same like in Cameroon, right? It's just a slight difference in resources, not a slight, no, there's important difference in resources. South Africa has the only walk-in P4 laboratory on the African continent. For those of you who don't know what a P4 laboratory is, a biosafety level 4 laboratory. You can read about it. I won't go into it. And there's other things that they do. I mean, every surveillance system should have an objective, right? Surveillance is not just done for surveillance. For example, let's take a clear example, COVID, where we know there are many asymptomatic cases, right? I think it's a complete waste of resources to go around the community sampling people who are not symptomatic, who are not a burden to the healthcare system. Understanding their impact on the transmission of the disease can be handled by targeted surveillance, where if you have a positive case, then you can go and do contact tracing, ask this person's household or workplace contacts and social contacts and sample them, and you know what percentage are asymptomatic. It's a lot more resource saving than say we want to do a general surveillance thing where we're going to the community and test people just because we want to know the number of people who are positive. One thing you want to know is how many people are positive. So what is the impact of the problem? But more important is how many people who have that condition are a burden to your healthcare system, right? Because you're not going to separate, you're not going to put the two into the same. Somebody who is severely sick who has to occupy a hospital bed, that could have been occupied by somebody who has been hit by a car. who is going to die because there's no hospital bed, right? It's one thing. So I think the whole issue of surveillance has to be grounded around setting specific objectives of that surveillance and having specific reasons why you do it. And that's why you have to do, usually at NICD, okay, when I was at NICD, surveillance system evaluations were done about every 3 years to see, are the objectives of your surveillance system still being met given the current form it is in? And if it needs to change, then you formulate recommendations, you identify why it needs to be changed. It's a constant quality improvement process. So that's what I'm going to say about the surveillance and the impact on asymptomatic diseases and the resources or the surveillance systems that are in South Africa. It's basically the same like what you have in Cameroon and what you have everywhere. Surveillance is surveillance. It's just the resources you put into that surveillance that changes.
Thanks a lot. Yeah, thanks a lot for those comments. Before I close, I just wanted to, I'm very sorry for putting on the spotlight, Dr. Bogoma Titanji. You've been a really very important voice in the last, throughout the pandemic has been very, very pertinent. I think, and I really wanted to invite your remarks and your thoughts on what are some things, some lessons that we've learned in the last 2 years that can really help us as we think about this subject moving forward. What are some things that we know today that we didn't know in 2019 that could potentially really help us as we think about pandemic preparedness moving forward? Dr. Bogoma.
Hi, Brian. I was content with being a passive listener today. I think that Villian gave such a brilliant presentation and really gave a tour de force around pandemic preparedness. Just to kind of reflect on the lessons that we've learned, I think that for me, the biggest lesson is that even the countries that on paper or in theory were supposed to be the countries that were most prepared for a pandemic, to respond to a pandemic, speaking specifically of countries like the United States or countries across Western Europe, the pandemic in itself was very humbling and actually highlighted that globally, the world is in the state of underpreparedness against any pandemic. And I think that that in itself should be a lesson, not only for countries within the African continent, but also countries in more developed settings to kind of think about pandemic responsiveness, not as something that any country can operate from an individual perspective. It really, really requires a lot of communication, collaboration, and talking to each other to be able to effectively respond to a pandemic. Because with a pandemic, it means that you're having multiple outbreaks of the same disease happening simultaneously everywhere. And Dr. Motaze made a very, very important point about the fact that, you can implement border closures, but there's no perfect border closure that's going to make a country become impermeable to a disease once you have a state of pandemic. So for me, the biggest lesson would be that we have to really think about pandemic preparedness more from a global and collaborative standpoint. And the WHO is trying to do some of that. There's a pandemic treaty that they've been working on, and it's planned to be signed in 2024. We'll see what ultimately makes it into that pandemic treaty. But I would say biggest lessons are humility, knowing that preparedness on paper doesn't necessarily translate into preparedness when you're faced with the crisis, and also learning that any approach that focuses on an individual country alone is doomed to fail, because once you're in a state of pandemic, everyone is affected and we're all interconnected. And I'll leave it at that.
Thanks, Bogoma. It's really deeply honored. We've learned a lot from you throughout in the last 3 years throughout the COVID-19 pandemic. And thanks a lot for your advocacy, your voice, the importance of community engagement, and really everything that you've done. And really, really, really very much appreciate it. Want to pass it over to Dr. Mono, just for his last comments, and Dr. Mono, who is the chair for the town hall. Dr. Mono.
Elvis, thank you. I don't know if you did call me for questions and I was not here, but my hand was raised, but I had multiple calls during the session. And I just want to thank Dr. Motaze Villain for everything. You know, it's important to say Villain taught me some of my first surgeries. We used to do surgery together at PMI, and I cannot forget that. So when I left school, so I'm very honored. He's been a colleague and a teacher to me at different levels. And your presentation today was very simple for everyone to understand what's going on. And concerning my remarks, really, as there's a question I usually ask: if we have a second COVID, is it going to be different? Reflecting here in the US, it's sad to say this, I feel it's not going to be much different, which actually makes me really scared. That did we learn anything from here? We did learn a lot. We have put in place several things that can help us with future pandemics. Are we going to be able, like the UK, to carry out research appropriately and be able to change decisions based on that? Are we going to be able to carry out research and not use emotions and be able to actually put in place clinical trials that can run effectively, and we can be able to start them up, get research data, informed clinical data from high quality research that's going to help us? I don't know if we're there yet, but that could be a discussion, as Dr. Henshaw and Dr. Motaze said, for some other day. And I'm honored to really have you guys come into this platform, teach us a lot. And being in oncology, I think there's something the research world can learn from us, which I'm going to share. We are very emotionless, let me put it that way. So we use, especially here in the US, we've used clinical trials in every step while we're doing treatment for patients. So our whole practice is engraved with clinical trials. So we are not scared to present trials to patients and tell them, you're going to get into a clinical trial no matter the stage, and try as much as possible, treat patients with what is available, know exactly what we don't know, and try to answer questions that we can help the next generation. So I think it should be a way forward too, as part of this discussion. But for preparedness, it's still a question I have. Are we even prepared as a world globally? And thank you very much for shedding light into this topic. And I think we're going to talk more in the parking lot for about 30 minutes or 1 hour, I don't know. So I just want to thank you for your time. Thank Professor Wisonge for his time and for being a mentor to a lot of young people who are here. Thanks Professor Alemji for coming here. He was our teacher. And I also want to thank Professor Malfobi for always taking time to come here. He's a big lesson to us. And if he can make time, I think a lot of us can sacrifice time to come and share our knowledge. And I'm truly humbled by the different organizations that make time to be here every day. So I just want to pass over the mic. Is it to Elvis or to Brian? God bless you all. And please, for those who have more to chip in this topic, there is the parking lot. We'll be there for about 30 minutes. If you have time, you can stay. If you're busy, please, you can log out, and then we'll meet in another 2 weeks. So thank you.
Thank you very much. Thank you, Mono. Responses to public health emergencies of international concern, challenges and perspective. That was the topic for today. And our presenter was Dr. Villain Kengafa. Thank you very much, ladies and gentlemen, for being part of this session for today. I want to thank Brian for the excellent coordination of the Q&A section of this town hall session. And I want to thank all those who have participated, your contributions. We can't emphasize how fortunate we are when we see our elder ones like Dr. Wisonge, Professor Wisonge and Alemji, all of them come to always support us. This is really, it's rare, you know, to find these really great professors still come to the town hall to listen to those whom they have mentored to speak, like William has demonstrated today, how excellent he is in this field of future pandemic preparedness. I want to thank you so much. He's really taken us across the entire span of how we can respond to a pandemic, not just looking at issues of supply chain and looking at issues of surveillance and looking at just the general issue, an important aspect of communication during pandemic. We learned from him that the pandemic communication or communication in public health does not just require a mere journalist to do that. You have experts who are supposed to really plan how we communicate around the pandemic. He has really, you know, just given us a lot in this presentation. I want to assure you, ladies and gentlemen, that the recorded version of this session will be downloaded and uploaded on our YouTube channel, available for public consumption. And so students and other faculties and members of the town hall who are not opportune to watch this live can always have the chance to watch this session. Once again, I want to thank you all. It's been a very great pleasure being with you this town hall session, and we look forward, as usual, to see you in a fortnight when we all be here again to look at yet another very important topic of public health interest. So once again, I wish you a nice weekend, and of course, stay back for the town hall parking lot session where we have the freedom to discuss whatever we want to discuss. Thank you.